Hello everyone, this is a presentation on dengue which is especially meant for medical professionals. Dengue is the most common and important arthropod-borne viral illness in humans. Dengue virus is a single positive stranded RNA virus. Positive stranded means the RNA can be directly translated into viral protein without any intermediate step of transcription. And the family is Flaviviridae, genus is Flavivirus, and there are four types, type 1, 2, 3, and 4. Transmission is by mosquitoes of the genus Aedes aegypti or Aedes albopictus, and they are widely distributed in subtropical and tropical areas of the world. Most of the cases are transmitted by Aedes aegypti. Dengue fever is typically a self-limited disease with a mortality rate of less than 1% when detected early and with access to proper medical care. When treated, severe dengue has a mortality rate of 2 to 5%, but if left untreated, the mortality can go as high as 20%. The infecting serotype appears to be the major determinant of DLY is lost, with DEN 2 and DEN 3 responsible for 59%. So DLY is the disability adjusted life year, which means amount of life year lost due to disability or due to premature mortality. WHO ranked dengue as one of the top 10 threats to global health in 2019. International Dengue Day is on 15th June in India and 16th May globally. Many cases of dengue infection go unrecognized because of absent or minimal symptoms. Incubation period is 4 to 10 days. Incubation period means the gap between mosquito bite and development of first symptom. Dengue symptoms usually last 2 to 7 days. And the symptoms are fever, which is very common and high grade and continuous, headache, especially behind the eyes, and pain behind the eyes is more on sideways looking. It is also called Bregman fever because of the severe muscle pain. It is especially prominent in the lower back, arms, and legs. Pain in joints, especially in knees and shoulders. Nausea and vomiting could also be there, but diarrhea is there. There could be altered taste sensation, there is rash, mild bleeding manifestations could be there, like petechia, the bleeding in the skin, bleeding gums, epistaxis from nose, menorrhagia, and hematuria. Sore throat, dry cough, and lymphadenopathy. Now we'll just discuss rash in a bit detail. So rash could be of two types. The first one, which is seen in early in the stage, is maculopapular or macular confluent rash over the face, thorax, and flexor surfaces with islands of skin spreading. It is described as islands of white in a sea of red. The rash typically begins on day 3 and persists for 2 to 3 days. There is a second type of rash which may occur within 1 to 2 days of defervations lasting 1 to 5 days. It is morbilliform, is maculopapular, spares the palms and soles and occasionally desquamates. And many times it is quite itchy. Now we'll go through the physical examination. So usually the patient looks very toxic. So patient is having high grade fever, severe body pain, and along with that, when you see his conjunctiva are injected, there is a facial flushing, which is a very sensitive and a specific predictor of dengue infection. The pharynx is inflamed. There could be lymphadenopathy. There could be tachycardia, bradycardia, or conduction defects. And we also have to do tourniquet test. The test is performed by inflating a blood pressure cuff on the upper arm to midway between diastolic and systolic blood pressure for 5 minutes. The results are considered to be positive if more than 20 petechiae per square inch are observed on the skin in the area that was under pressure. Diagnosis is by virus isolation, nucleic acid detection, and antigen detection. At the end of the acute phase of illness, serology becomes the method of choice. So RT-PCR yields a serotype-specific diagnosis very rapidly. It is most useful early in the course of illness. It is not susceptible to the cross-reactivity with other flaviviruses like yellow fever virus seen with the serologic testing. The CDC currently recommends that within the first week of illness, diagnostic testing should include a test for dengue virus, RT-PCR or NS1 antigen, and IgM anti-dengue virus. NS1 antigen kits are now available, which can be done, and the reports are available within 30 minutes. NS1 may be positive up to 12 days after fever. Recovery is complete but slow, with fatigue and exhaustion often persisting after the fever has subsided. The convalescent phase may last for 2 weeks. A patient who has been infected with one serotype becomes immune to that serotype for the rest of his life. But immunity to other serotypes is there, which is called heterotypic immunity. So heterotypic immunity is there only for 2 to 3 years. After that period, if he gets infected with another serotype, then he may develop bleeding and endothelial leak. And this syndrome is termed severe dengue. It was reclassified in 2009 by the WHO, and it was previously referred to as dengue hemorrhagic fever and dengue shock syndrome. So, what is the pathogenesis of severe dengue? So, severe dengue has also been termed dengue vasculopathy, means the blood vessels are involved. Vascular leakage due to increased capillary permeability in these patients results in hemoconcentration and serous effusions and can lead to circulatory collapse. This, along with severe hemorrhagic complications, can lead to a shock syndrome which poses a greater fatality risk than bleeding per se. Severe dengue, what are the signs and symptoms? So initial phase of severe dengue is similar to that of dengue fever and other febrile viral illnesses. But shortly after the fever breaks, which could be 3 to 7 days after symptom onset, signs of plasma leakage appear along with the development of hemorrhagic symptoms. The subsequent 24 hours frequently prove critical. If left untreated, then hemorrhagic fever most likely progresses to shock. Hemorrhagic symptoms are bleeding from sites of trauma, gastrointestinal bleeding, which may manifest as black tarry stool or red color stool, and hematuria, means blood in the urine. And the signs are conjunctival injection in approximately one third of patients, pharyngeal injection, 97% of patients, and more than 50% of patients have a positive tourniquet test. And common symptoms of impending shock means soon the patient will go in shock. So the symptoms are abdominal pain and tenderness, along with lethargy and restlessness, clinical fluid accumulation like signs of ascites or pleural effusion, altered mental status, mucosal bleeding, and persistent vomiting. In 20 to 30% of dengue hemorrhagic fever cases, the patient develops shock, which is known as dengue shock syndrome. Findings of dengue shock syndrome are signs of decreased peripheral perfusion like cold, pale, clammy, and mottled skin, tachypnea, brady or tachycardia associated with hypovolemic shock, hypotension, and narrow pulse pressure, I mean less than 20 millimeter mercury, and hepatomegaly, which is more than 2 centimeter. So now we will go through hemodynamic assessment. So continuum of hemodynamic changes in a patient with a stable circulation to compensated shock to hypotensive shock. So the first parameter is alertness level, consciousness level of the patient. Here it is written wrongly as hypotensive shock. This this picture and many other pictures which will come now in the presentation have been taken from WHO guideline for treatment of dengue hemorrhagic fever. The link will be given in the description. So the first criteria is the consciousness level, alertness of the patient. So it is quite clear and lucid in stable patients, clear and lucid in compensated shock also, but shock can be missed if you do not touch the patient. In hypotensive shock, there is change of mental state, so there will be restlessness and combativeness. So capillary refill time is brisk, less than 2 seconds in stable patient, prolonged more than 2 seconds in compensated shock, and very prolonged and mottled skin in hypotensive shock. Extremities are warm and pink in stable circulation, cool peripheries in compensated shock, cold clammy extremities in hypotensive shock. Peripheral pulse volume is good in stable circulation, weak and thready in compensated shock, feeble or absent in hypotensive shock. Heart rate is normal for A's in stable circulation. Tachycardia will be there in compensated shock. Severe tachycardia with bradycardia in late shock. Blood pressure is normal for A's and normal pulse pressure for A's in stable patients. And normal systolic pressure but rising diastolic pressure, which causes narrowing of pulse pressure, and therefore patient manifests with postural hypotension in compensated shock, and narrowed pulse pressure, that is less than 20 millimeter mercury, and hypotension and unrecordable blood pressure in hypotensive shock. Respiratory rate is normal for age in stable patients. Tachypnea is there in compensated shock, and metabolic acidosis with hypernia and Kussmaul's breathing in hypotensive shock. We will now go through criteria for the diagnosis of severe dengue fever as per WHO. So, severe dengue is defined as dengue with any of the following, like severe plasma leakage leading to shock or respiratory distress, or severe hemorrhage, or any organ failure like liver, with AST, I mean SGOT and ALT, I mean SGPT more than 1000. So in any dengue, SGOT and SGPT are raised. But if they are raised more than 1000, it means there is liver necrosis. In CNS, if there is any impaired consciousness, encephalopathy, encephalitis, or in heart, if the patient develops cardiomyopathy. So if any of these criteria are fulfilled, along with a confirmed case of dengue, then it is defined as severe dengue. Reasons for impaired consciousness. So encephalopathy is a rare complication that may result from a combination of cerebral edema, intracranial hemorrhage, anoxia, hyponatremia, and hepatic injury. So the tests which are done in dengue are CBC, which is done on daily basis to look for platelet count and hematocrit level. Metabolic panel, liver function test including serum protein and albumin. Coagulation panel with or without disseminated intravascular coagulation panel, that is DIC panel. Arterial blood gas to assess pH, oxygenation and ventilation. Chest X-ray to look for pleural effusion and bronchopneumonia. Right-sided pleural effusion is quite typical. Bilateral pleural effusions are common in patients with dengue shock syndrome. Ultrasonography the findings include pleural effusion, ascites, pericardial effusion, and a thickened gallbladder wall. Thickening of the gallbladder wall may precede clinically significant vascular permeability. Head CT without contrast in patients with altered level of consciousness, and leukopenia, lymphopenia near the end of the febrile phase, and thrombocytopenia are common findings in dengue fever and are believed to be caused by direct destructive action of the virus on the bone marrow precursor cells. And because of this destructive action of virus on the bone marrow, patient gets severe body ache. Have findings in severe dengue. So there could be progressive thrombocytopenia and leukopenia. Lymphocytosis, often with atypical lymphocytes, commonly develops before deprivation or the onset of shock. Increasing hematocrit, which is 20% absolute rise from baseline. Low albumin, which is a sign of hemoconcentration preceding shock. Progressive effusions, elevated transaminase levels mildly or in several thousands. Low fibrinogen and elevated fibrin split products are signs of disseminated intravascular coagulation, severe metabolic acidosis. Now, management. So, management decisions depend on the clinical manifestations and other circumstances. So, there are three groups. So, patient could be sent home, which is group A. They may be referred for in-hospital management, group B, or they require emergency treatment and urgent referral, which comes in the group C. So, what are the patients included in group A? These are the patients who are able to tolerate adequate volumes of oral fluids. They are passing urine at least once every 6 hours and they do not have any of the warning signs, particularly when the fever subsides. Patients who are sent home should be monitored daily by healthcare providers for temperature pattern, volume of fluid intake and losses, urine output, volume and frequency, warning signs, signs of plasma leakage and bleeding, hematocrit and WBC count and platelet. Patients who are sent home for the care, they should be given this home care card, which they should bring to health facility for each visit. And what they have to do, they should be advised to have adequate bed rest and adequate fluid intake like milk, fruit juice. But we should be cautious in diabetic patients, isotonic electrolyte solution, ORS, and barley water, rice water, and coconut water. Plain water alone may cause electrolyte imbalance. They can take paracetamol, but not more than 4 grams per day for adults and accordingly in children. If paracetamol is not enough to bring down the fever, then they have to go for tepid sponging. They should look for mosquito breeding places in and around the home and eliminate them. And what all medicines they have to avoid? They have to avoid NSAIDs or steroids because they increase the chance of bleeding. If someone is already taking ecosprin for his heart problem, then he should not be advised to stop the ecosprin immediately. His platelet count and bleeding manifestation should be monitored on daily basis, and if he shows any bleeding manifestation or if the platelet count goes below 80,000, ecosprin should be stopped. But once the patient's platelet count starts improving and it is more than 50,000, the ecosprin should also again be started. Antibiotics are not necessary. And he should be advised of the danger signs. So the danger signs or the warning signs are bleeding, so red spots or patches on the skin, bleeding from nose or gums, vomiting blood, black colored stools, heavy menstruation or vaginal bleeding. If the patient is frequently vomiting, so he couldn't have enough fluid intake. So if he is having severe abdominal pain, which usually suggests impending shock, drowsiness, mental confusion, or seizures, pale, cold, or clammy hands and feet, difficulty in breathing. And whenever they come to the health facility, every visit we should check their hematocrit, WBC count, and platelet count. Group B. So they should be referred for in-hospital management. What are the criteria for admission? So either they are having warning signs, as we read just now, signs and symptoms related to hypotension, so which suggests plasma leakage. So patient will be dehydrated, unable to tolerate oral fluids, giddiness or postural hypotension, profuse perspiration, fainting, prostration during deprivations, hypotension or cold extremities. If there are signs of bleeding, like a spontaneous bleeding independent of the platelet count. Organ impairment, so either kidney, hepatic, neurological, or cardiac impairment. And last, tender liver, although not yet in shock, chest pain or respiratory distress, or cyanosis. So findings through the blood investigation. So if it suggests rising hematocrit, especially if it is 20% above the baseline, pleural effusion, ascites, or asymptomatic gallbladder thickening. If the patient is not having any of these danger signs, but he is having some coexisting conditions like pregnancy, comorbid conditions such as diabetes mellitus, hypertension, peptic ulcer, hemolytic anemias, and others. And if the patient is overweight or obese, then rapid venous access is difficult in emergency. So they should be also admitted. Infancy or old age. So these two age groups are very susceptible for severe dengue. Social circumstances like patient is living alone, living far from health facility without reliable means of transport. So now we will go through the treatment of compensated shock. So fluid resuscitation is started with isotonic crystalloid. Based on 3 randomized control trials in dengue shock in children, there is no clear advantage to the use of colloids over crystalloids in terms of the overall outcome. However, colloids may be preferred choice if the blood pressure has to be restored urgently, that is in those with pulse pressure less than 10 millimeter mercury. So normally in compensated shock, the fluid resuscitation is started with isotonic crystalloid at the rate of 5 to 10 ml per kg per hour over 1 hour. And then the patient is assessed hemodynamically. How the monitoring of the patient is done, we will read in the next slide. So now, if suppose the patient has improved hemodynamically, and then we reduce the IV crystalloid to 5 to 7 ml per kg per hour for 1 to 2 hours, and then further to 3 to 5 ml per kg per hour for 2 to 4 hours, and then further to 2 to 3 ml per kg per hour for the next 2 to 4 hours. If the patient continues to improve, fluid can be further reduced. If suppose patient does not show any sign of hemodynamic improvement, then we have to check the hematocrit. If hematocrit is still increased or it is increasing, then we have to administer second bolus of fluid, which is even at the faster rate of 10 to 20 ml per kg per hour for 1 hour. If there is improvement, then we go back to the rate of 7 to 10 ml per kg per hour for 1 to 2 hours, and then gradually we reduce as the patient improves. If suppose even after the second bolus the patient has not improved, we again check the hematocrit, and again based on whether hematocrit is high or decreased, we see whether to give another bolus of fluid. If suppose hematocrit has decreased after the bolus of fluid, then it means there is significant occult or overt bleed. So we have to initiate transfusion with fresh whole blood. Now monitoring during fluid resuscitation. So we have to give the minimum IV fluid volume required to maintain good perfusion and urine output of about 0.5 ml per kg per hour. IV fluids are usually needed for only 1 to 2 days. Reduce IV fluids gradually when the rate of plasma leakage decreases towards the end of the critical phase. This is indicated by urine output and or oral fluid intake that is or are adequate, or hematocrit decreasing below the baseline value in a stable patient. So a detailed fluid balance should be maintained, and the parameters to be checked are vital signs and peripheral perfusion every 1 to 4 hours until the patient is out of the critical phase, urine output every 4 to 6 hours, hematocrit before and after fluid replacement, and then 6 to 12 hourly, blood glucose and other organ functions such as kidney profile, liver profile, coagulation profile as indicated. Now we will go through the management of patients who require emergency treatment and urgent referral when they have severe dengue. So, if the patient is in hypotensive shock, fluid resuscitation with 20 ml per kg of isotonic crystalloid or colloid over 15 minutes is given. And then we obtain and try to obtain a hematocrit level before fluid resuscitation. If suppose the patient improves hemodynamically, then crystalloid or colloid is given at the rate of 10 ml per kg per hour for 1 hour, and then as the patient is improving, the rate is gradually reduced. If patient continues to improve, fluid can be further reduced, and hematocrit has to be monitored every 6 hours. If suppose there is no hemodynamic improvement in the patient, then we have to review the first hematocrit. So if the hematocrit is increased, then we have to administer second bolus fluid, which is colloid, 10 to 20 ml per kg over half to 1 hour. If there is improvement, okay, then we have to go to the crystalloid or colloid and gradually reduce the fluid infusion rate. If there is no improvement, then we have to repeat the hematocrit for second time, and if hematocrit is still on high side, then third bolus of fluid is given. If patient improves, well and good. If not, then repeat the third hematocrit, and similarly we have to go. If suppose by after the any hematocrit testing, if hematocrit has come down but patient has not improved, then it means occult or overt bleed, and then again we have to transfuse the patient with fresh whole blood. Again, the monitoring in patients with shock. So vital signs and peripheral perfusion every 15 to 30 minutes until the patient is out of shock, then 1 to 2 hourly. And we have to place an arterial line for accurate estimation of BP and frequent blood sampling. ECG and pulse oximetry should be there. Urine output, so we can also place continuous bladder catheter. Otherwise, urine output is done, urine output is checked every hour till the patient is out of shock, then 1 to 2 hourly. And acceptable urine output is same as earlier, it was 0.5 ml per kg per hour. Hematocrit should be monitored before and after fluid boluses until stable, then 4 to 6 hourly. Arterial or venous blood gases, lactate, total carbon dioxide or bicarbonate every 30 minutes to 1 hour until patient is stable, then as indicated. Blood glucose before fluid resuscitation and repeat as indicated. And other organ functions such as renal profile, liver profile, coagulation profile before resuscitation. Now we have seen that in the management of patient with compensated shock and hypotensive shock, the measurement of hematocrit is very important, but we should interpret the values of hematocrit very carefully. So we have to consider two things, hematocrit as well as hemodynamic status. So there could be four situations. First, rising or persistently high hematocrit with unstable, especially narrowing of the pulse pressure. So hemodynamically patient is unstable, but the along with that hematocrit is rising. So clinical interpretation is active plasma leakage is there, and we have to give further bolus of fluid replacement. If hematocrit is rising or persistently high, but patient has become stable, then it means condition is improving, and if we keep following the patient, then within next 24 hours hematocrit will also start coming down and the plasma leakage will stop. So it does not require extra intravenous fluid. So clinical assessment of patient is very important, not only the hematocrit. If suppose hematocrit is decreasing and patient is unstable, it means there is a major hemorrhage, and as we have seen, urgent fresh blood transfusion is required. If hematocrit is also decreasing and patient is also stable, this is the ideal situation that we look for. And if suppose this happens, then there is a hemodilution and or reabsorption of extravascular fluids. So IV fluids must be discontinued immediately to avoid pulmonary edema. Patients at risk of major bleeding. So those who have prolonged or refractory shock, either have hypotensive shock and renal or liver failure and or severe and persistent metabolic acidosis, or those who are given NSAIDs or have pre-existing peptic ulcer disease or are on anticoagulant therapy, or if they have any form of trauma including intramuscular injection, or the patients with hemolytic conditions, they are at risk of major bleeding. So indicators of severe bleeding, that bleeding is going on. So persistent and or severe overt bleeding in the presence of unstable hemodynamic status regardless of the hematocrit level. A decrease in hematocrit after fluid resuscitation together with unstable hemodynamic status, as we have seen in last slide. Refractory shock that fails to respond to consecutive fluid resuscitation of 40 to 60 ml per kg. So then also we have to think of bleeding. Hypotensive shock with low or normal hematocrit before fluid resuscitation, persistent or worsening metabolic acidosis with or without a well-maintained systolic blood pressure, especially in those with severe abdominal tenderness and distension. Now, how to treat? So, mucosal bleeding may occur in any patient with dengue, but if the patient remains stable with fluid resuscitation or replacement, it should be considered as minor. If major bleeding occurs, it is usually from the GIT or vagina in adult females. In patients with profound thrombocytopenia, we have to ensure strict bed rest and protect from trauma to reduce the risk of bleeding. So, do not give any intramuscular injections and but the prophylactic platelet transfusions for severe thrombocytopenia in otherwise hemodynamically stable patients have not been shown to be effective and are not necessary. Action plan for the treatment of hemorrhagic complications. So give 5 to 10 ml per kg of fresh packed red cells or double of this amount of fresh whole blood at an appropriate rate and observe the clinical response. So it can be observed by hemodynamic status and acid base balance. It is important that fresh whole blood or fresh red cells are given because oxygen delivery at tissue level is optimal with high level of 2,3-diphosphoglycerate, that is 2,3-DPG. Stored blood loses 2,3-DPG. Consider repeating the blood transfusion if there is further blood loss or no appropriate rise in hematocrit after blood transfusion. There is little evidence to support the practice of transfusing platelet concentrates and or fresh frozen plasma for severe bleeding. It has been practiced when massive bleeding cannot be managed with just fresh whole blood or fresh packed cells, but it may exacerbate the fluid overload. Now, criteria for discharge from hospital. If the patient is afebrile for 24 hours without any antipyretic, good appetite, clinically improved condition, adequate urine output, stable hematocrit level, at least 48 hours since recovery from shock, no respiratory distress, and platelet count is greater than 50,000 cells per microliter. Now, in a special situation of pregnancy. So, dengue in pregnancy must be carefully differentiated from preeclampsia, I mean, dengue shock. Pregnant women who develop dengue is at higher risk of miscarriage, low birth weight, and premature birth. Factors that increase the severity. Patient age, so severe disease is more common in babies and young children. Pregnancy, nutritional status, more severe in children who are relatively well nourished. Ethnicity, sequence of infection with different dengue serotypes. So the risk of severe disease from secondary infection increases if someone previously exposed to serotype dengue virus 1 contracts serotype 2 or 3, or if someone previously exposed to type 3 acquires type 2. Now, viral genotype, quality and extent of available medical care, comorbidity. Dengue can be life-threatening in people with chronic diseases such as diabetes and asthma. Other risk factors are female sex, high body mass index, and viral load. Genetic polymorphism. G6PD deficiency increases the risk. Polymorphism in the gene for the vitamin D receptor and Fc gamma receptor seem to offer protection against severe disease in secondary dengue infection. Complications are heart involvement causing cardiomyopathy, seizures, encephalopathy, and viral encephalitis, hepatic injury, depression, pneumonia, iritis, orchitis, ophoritis, sensory neural hearing loss, and optic neuropathy, which can sometimes result in permanent and significant visual impairment. Transmission from mosquitoes. So Aedes mosquitoes species have adapted well to human habitation, often breeding around dwellings in a very small amount of stagnant water found in old tires or other small containers discarded by humans. Even a bottle cap filled with water can serve as to incubate and hatch Aedes eggs. The eggs of Aedes mosquitoes withstand long periods of desiccation, reportedly as long as 1 year, but are killed by temperature of less than 10 degrees Celsius. Rare cases of vertical dengue transmission have been reported. Humans are the preferred hosts. Female Aedes mosquitoes are daytime feeders. They inflict an innocuous bite, usually on the back of the neck and the ankles, and are easily disturbed during a blood meal, causing them to move on to finish a meal on another individual, making them efficient vectors. Not uncommonly, entire families develop infection within a 24 to 36-hour period, presumably from the bites of a single infected mosquito. Transmission from humans. An individual with dengue is capable of transmitting the virus for 4 to 5 days, maximum 12 days, to a capable vector. Persons with dengue viruses in their blood can transmit the viruses to the mosquito 1 day before the onset of the febrile period. After an incubation period of 5 to 10 days, the infected mosquito can transmit virus for the rest of its lifespan, which could be up to 1 month. Now, prevention. So we should wear N-diethyl 3-methylbenjamide, that is DEET, containing mosquito repellent. It is a mosquito repellent. I mean, the mosquitoes don't like its smell, so if someone has applied, they don't come near that patient. But it is not that they will not bite if they come. Wear protective clothing, preferably impregnated with permethrin insecticide. Remain in well screened or air conditioned places, which is not always possible. The use of mosquito netting is of limited benefit as Aedes are daytime biting mosquitoes. Eliminate the mosquito vector using indoor sprays. The most widely used mosquito control technique, spraying cities to kill adult mosquitoes, is not effective. So efforts should target the larval phase with larvicides and cleaning up larva habitats. Eliminate small accumulations of stagnant water around human habitats, for example, disposing of old tires, etc. Support community-based vector programs, including source reduction and the use of vectoricidal agents, including predatory copepods as biological control agents. Only thing with biological control agents is that you have to replace them again and again. Now, recent advances. In 2011, an Australian research effort infected Aedes aegypti mosquitoes with the intracellular bacterium Wolbachia in the laboratory. Maternally inherited Wolbachia prevents dengue virus from replicating within mosquitoes. They then release these mosquitoes in the wild to mate with wild mosquitoes and pass the Wolbachia along to their offspring. After releasing approximately 10 mosquitoes per house per week for 10 weeks, they found that greater than 80% of collected wild mosquitoes had this infection. Infected mosquitoes laid fewer eggs and exhibited shorter lifespans. The research group plans further field trials in Vietnam, Indonesia, and Brazil. If successful, this would provide a practical biological approach to dengue suppression. Vaccine. One vaccine is currently approved for the prevention of dengue infection. It is by Sanofi Pasteur, registered as Dengvaxia, CYDTTDV, in several countries in the late 2015 and 16. It is based on a weakened combination of the yellow fever virus, which is again a flavivirus, and each of the four dengue serotypes. Studies of the vaccine found it was 66% effective and prevented more than 80 to 90% of severe cases. Dengue vaccine was approved by the FDA in 2019 for prevention of dengue disease caused by dengue virus serotypes 1, 2, 3, and 4 in individuals aged 9 to 16 years with laboratory confirmed previous dengue infection who live in endemic areas. So it is approved only in individuals who have been previously infected. Persons not previously infected are at increased risk of severe dengue disease when vaccinated and subsequently infected with the dengue virus. Thank you.